National health insurance, that's what we're talking about this evening on Mansfield's Money Sense. Andre Jacobs, the business unit head of national healthcare operations at Aon South Africa. Alex van den Heever, and I've got to apologise to you. I'm sorry, Professor. He's Professor of Social Security at Wits. And Lerato Moloi, Municipal Outreach Officer at the South African Institute of Race Relations. Our guests in the studio this evening talking about this whole health insurance, national health insurance document that's out there and is being debated, and the debates, it's the right thing to do, to talk our way through these things. As you were saying, Andre, this is a work in progress, really. But to get away from the negativity of it, let us make an assumption, because government has made a huge amount of assumptions in the document itself. Let's make an assumption that this works. Could this, if it works, be a way forward, not only for South Africa, but for the rest of Africa as well?
If it works, and so we're working on the assumption.
Stop being negative.
Not being negative, being realistic.
Yeah, okay.
Well, firstly, I'd just like to say, in terms of the realism of it, and looking back at what has happened in the past, I don't know if you watched Carte Blanche this weekend with Universitas Academic Hospital in Bloem, where there was a state-of-the-art pediatric high care unit that was donated by KFC, and the executive producer of Carte Blanche went to visit one weekend to check how the high care unit was doing, and it was padlocked. Now, there's a classic example of resources being put into the public healthcare system and nothing coming out of it. At Bara, I had a state-of-the-art cardiac unit with state-of-the-art equipment meant to revolutionize the public healthcare system, and there were water leakages that ruined it. So if we're working on those examples, and there are many more, it's very hard to take this NHI proposal and see how it would work.
You are itching. I'm trying to keep it positive here, but it seems that it doesn't seem that anyone on the panel is that positive about it, to be honest.
I think that part of it has to be looking at the reality of the content of what is proposed, because it's not a question of whether, what if this works, it's a question as to whether or not the recommendations make sense. And just one example is it proposes typically in a publicly driven health system, you do not have a centralized purchasing structure, but it proposes one. So that doesn't work just as a design element, but it's being created essentially for what reason? It's a completely artificial attachment in the entire design of the public health system. So that's one design element, which is very strange. And the 6% of GDP proposal, all of our comparable countries tax at around about what we tax, about 3.4, 3.5%, maybe at the high end about 4% of GDP for their public systems. We're not out of kilter with that, but where we are out of kilter is that our healthcare delivery is appalling for what we're spending. So when we compare side by side with other countries of our level of development and our level of public expenditure on health, they outperform us massively.
Okay, so we literally are saying it's a difference between private and public here. And as a citizen of the country, I have got to, if I want my children to be educated well, I've got to purchase private education. If I want to be secure at home, I've got to purchase private security. If I want decent medical care, I've got to purchase private medical care. And we now moving this into a public sector. Is this government abdicating its responsibility to its citizens by shifting the money to another sector?
Jeremy, I think, again, somebody mentioned it the other day to me, which I think is a very important statement, is that she's got somebody working in her house, and both of them are mothers. If their children gets ill, then the one have got a better chance to survive than the other one. Alex spoke about it. Our maternal mortality rate is actually comparable with the Comores, which is shocking. And I think that's really not good. So I would rather argue from the point of view not how it affects me in a certain sense on the private side, in the private sector, but actually the rest of the population. We need to find a way of improving the quality and I'll use the words of the Minister of Health, the problems in the public healthcare system needs to be fixed. Alex speaks about some systemic problems. There's major problems. At a big debate that we had a couple of years ago, Alex was on that program also. Some of the doctors in the public sector were exceptionally upset about the fact that they cannot make healthcare decisions. And that those decisions are made centrally, and that it has a huge impact. I think some of the doctors are performing miracles in the public sector, not with the money that they have, but in terms of the support that they have and the obstructiveness of the system. So there's a lot of work to be done in the public sector. And I agree, there is not more money that we need in the public sector, but a proper governance sector system. And those things were proposed years ago. In many research papers that we have, where we speak about the district health system and delegating the healthcare decisions down as low as possible. Those suggestions were good and well-founded and well thought-through proposals, but that was not implemented. It is time that we start implementing some of the good research and the good suggestions that came out of those research.
So we've got the people, we've got the ability.
Well,
it's creating the environment.
Creating the environment, and before the Green Paper does say we need an overhaul, a complete overhaul of the healthcare system. They don't say exactly what that overhaul is. They don't say how they're going to deal with all the problems that the healthcare system is facing. So I think before we go dramatic, so to speak, let's fix what we have now. Let's see if it can be done, and then work towards building something such as NHI.
Would you agree with that, Alex?
Well, I think first of all, in terms of the protection offered by our total health system, public and private, there are gaps in both the public and the private sector that need to be addressed. You don't just address one part of the system. So firstly, part of looking at the Green Paper, it lacks a holistic response to our current problems. You're not effectively protected in the private sector. There are lots of gaps in the insurance environment that mean that people aren't fully protected. There are a lot of issues where the costs are not effectively contained. We've also got a trapped group in there because they don't have alternatives within the state. So if you've got income, you buy yourself out, and you're not always as protected as you could be. The state system, if you grow at GDP, you keep a constant rate of GDP expenditure as a percentage of GDP, you will have the growth rate of the economy to build into that. It doesn't mean that it's not adding new money. If you look at that growth rate, there's substantial improvements in the public health system coming just from economic growth. Our issue is, can government address the vested interests within the public system that are preventing it from operating effectively? Those vested interests are the people who are corruptly being allocated contracts and in many instances inappropriately being allocated positions in running hospitals, running districts and running core services. That has caused the systemic collapse of a large part of the public system. Now that is not addressed because it's a political hot potato for people. So what's being asked for is extra money when the elephant in the room is completely ignored.
Is there any system like this proposal that is working in the rest of Africa?
Africa itself has got very few systems that provide universal healthcare. There's an enormous drive from Africa, enormous need for Africa to actually provide more universal cover. And I recently was in Italy at the ILO lecture on social health insurance, and the amount of people from Africa that was there was enormously encouraging. What's concerning to me is if some of those countries, which are far less privileged than us, actually get it right, and we actually sit with an economy and the infrastructure that is far more privileged than that. So we need to actually do something and rather lead Africa than Africa leading us.
So this has to work.
It must work, and
We've got to make this work not only for us, because it's necessary for us, but to drive it through the entire continent. If there was one thing you could change about this whole thing, what would you do?
Let's sort out the governance. Let's make people accountable for the choices that they make. Let's get more personnel who are professional and can treat patients properly. Then, when that works and we have more faith in the public healthcare
Then
system,
you can put money into it.
let's do it.
Alex?
Yeah, I think that it's absolutely critical that we depoliticize this particular debate so that people can talk openly about it. A lot of people have not been able to.
Yeah.
And that in a proper debate and discussion on healthcare reform, we are able to have the issues that are wrong with the system tabled for a holistic response. South Africa has got a universal access system. It's got universal coverage, but it's got holes throughout the system that need to be corrected. None of them are addressed in the Green Paper.
Andre?
get the business, Unity South Africa, get Netlac involved and make sure that they actually contribute positively to the debate with the Department of Health, with the Minister, and have an honest and intellectual approach towards the solution.
Thank you, guys, and gorgeous lady, for joining me this evening. Very interesting discussion.